Reasonable failure to treat pain is viewed as an unethical breach of human rights. This is a quote from the World Health Organization, and that just really emphasizes what we've been talking about, that you need to value what your patients are telling you about their pain and make sure that you're addressing it as part of your nursing process. So earlier I mentioned that one of the influencing factors was age and developmental stage. So let's look at some of the differences between some of the behavioral and interventions that you do between some of the different age groups. So here we have pain in the infants. Now for the infants, the example we often think of is either immunizations or circumcisions. So we've all seen the babies cry when they get their shots. So it's really appropriate that the scale that is used for assessing an infant's pain is called the CRIES scale. So the one that I really want you to pay the most attention to here is their crying. They get a 0 for no crying. High-pitched consolable, we can make them happy, they get a 1. Inconsolable, they get a 2. Required oxygen, we need to give them extra oxygen. If their heart rate's going up, they get a higher rating. Their expression, the more unhappy they are, the higher pain rating they get. And sleeplessness, the more that they are constantly awake, that they are unable to get rest, is also the higher their pain scale rating is. So their behavior, they are going to perceive pain. There was probably an argument for a long time in pediatrics, oh, the babies can't feel pain. Don't worry about it. They can perceive the pain, and they cry, and they respond by squirming around and having that extra activity. So some of the interventions that you can do, swaddle them, make them feel secure. The glucose water is a great thing. Offering them a pacifier or soothing them with singing or music. The glucose water, that was actually used when my son had his circumcision. They wheeled him off to the nursery and they gave him that because when he came back he looked like he'd had a glazed donut. I don't know. So, but it helps. And then the breastfeeding, actually, do you guys have had Miss Endress in the skills lab? Her graduate project for her intervention was working on a labor and delivery unit. And she instituted a policy where she was working when they were giving immunizations and taking blood from infants of having the baby be on mom's breast while they were doing that. So the infant was much calmer and the whole process was less painful for the baby. Now, pain in toddlers. Now these guys are a little more savvy. They've been around the block and they know that the shot's coming and they know that it's going to be painful. When my son got his next set of immunizations, and my husband works at the place in the clinic where he got his immunizations, my son was used to going there, visiting dad. This wasn't a scary place at all. After he got his immunizations, I don't want to go down that hallway at all. I remember what happened to me the last time I went down there. So these are the guys that you can distract with toys and talk to them about it. But definitely tell them the truth. If it's a shot and it's going to hurt, don't say, oh no, it's not going to hurt. Tell them it's going to hurt, but just a little. You can allow the comfort items and allow them to have the same procedure on that. That's a lot of times when they take the little kids to surgery and they also put a cast on the little bear. Oh, the little bear has the same cast that you do. Okay. Their behavior, they are able to describe their pain. They will also respond with crying and anger. But they may think that the pain is a punishment. So you kind of have to deal with that misconception with the little people. For the school-age children, again, it's really important to be honest with them and let them know what to expect. They're going to try and be more brave. And depending on their age, they may more regress into some of the babying behaviors and let mom and dad treat them more like a baby. They respond well to explanations. Again, really be honest with what they can expect, be supportive and nurturing, and so much of that is that distraction from their iPads and their TV, their video games. That's really a good way to distract them from the pain. The adolescents, now they're going to try and be tough and brave in front of their peers especially, and they see pain as giving in. But they're another one that, especially if you can allow them to make choices in their pain modulation, let them, and they are definitely going to be the group that you need to be the most aware and sensitive with privacy. So if you do have to give them an injection and it has to be IM, depending on what their body mass is, you may really want to do an IM in the deltoid, even though ventrogluteal would be really good. They may be so reluctant to let you see them there. You may want to modify your plan of care to help conserve their sense of privacy. Then we move on to pain in the older adult. This is really one of the areas that is pain is really underreported and unrecognized. A lot of the older adults have fear and confusion about it, and sometimes there's a lot of nurse bias about pain in the older adult. The underreporting in the acute care setting, and then the underreporting in the long-term setting. Some of the older adults may just feel like, oh, I'm just old and I should be old and in pain, when that's not necessarily the way it needs to be. If they're nonverbal or they have dementia, then there may be issues with how they are able to express their pain. So this goes back to that slide where we were talking about of looking for some of those nonverbal cues. Has their activities changed? Are they not participating in some of the activities in that long-term care facility like they used to? Are they not eating like they used to? How are their vital signs? And have you noticed that they are having some of that muscle atrophy because they're not participating? One of the biggest challenges in pain in the older adults is the polypharmacy. Have you guys started to explore that in some of your other classes? Where they are just on so many medications. They're on a lot of medications that interact with each other. So this is when using some of the non-pharmacological pain relief is more beneficial for some of the older adults. Think about a lot of some of the complications and side effects of the pharmacological interventions of opioids, constipation, decreased respiratory. These are some of the things that we definitely don't want in anybody, but especially in some of the older adults that already have problems with breathing or may already have issues with their bowels. Due to those physiological changes, there needs to be some dosing considerations. These patients already maybe have some decreased kidney function, and some of the medications that are processed in the kidney, so that's a dosing consideration that needs to be considered by the provider, but something that as the nurse you should be aware of too. Now, chronic pain affects 25 to 50% of the older adults living in the community, and there's just a higher prevalence of acute and chronic pain in this population. And that brings us to the special population of cancer pain. This picture I have up here is someone with a Mediport or a Portacath. Have any of you seen that yet? So there are some medications and different procedures that you can use ahead of time to kind of help that. When the patients come in for access to that, that's a painful procedure. So using some therapies to minimize the pain of accessing that port is a good thing to manage too. But cancer pain is a subcategory of chronic pain. And it may be associated with also with episodes of acute pain. The pain can be a result of the cancer infiltrating into an organ or the result of the tumor pressing on other structures and causing that mechanical pain. There can be pain resulting from the treatments like a radiation burn, but really the larger issue here is their quality of life, and it's maybe needed to have a mix of many potent medications and alternative therapies to provide them that relief. So now we go on to the next process, part of the nursing process, the diagnosis. You guys are getting ready to do your nursing care plan and your clinicals. So we get to a nursing diagnosis of acute pain, and we got to have it be related to something. So this person is having acute pain related to an injuring agent. That might be physical, that might be psychological. As evidenced by the patient's report of pain or narrowed focus. They're only able to focus on the fact that they're having pain. That loss of appetite or an inability to perform their activities of daily living, the ADLs. What do we want them to do? Their desired outcomes. We want them to verbalize some pain relief methods. We're going to teach them. We want them to report pain relief to a satisfactory level and an improvement in their vital signs. So now, after the diagnosis comes your plan. What can we do to help the patient reach these goals? Well, first we need to consider the individual. And we can use some pharmacological and non-pharmacological strategies. But that pain needs attention. And then using some non-judgmental care, we're going to address the patient's anxiety, their fear, their sense of powerlessness. They might have some insomnia, and then they may also have some spiritual distress. Sometimes these patients feel that if they're a spiritual person, this may be a punishment. And like we were saying with the kids, they may feel like the pain is a punishment. The next step in the process is your intervention. As part of your plan, you're including in your intervention strategies for managing the patient's pain and for helping them in that modulation of that pain. So to do that, we have to acknowledge and accept the patient's pain and assist any of their supporting persons, especially that laboring mom supporting their support person so that they can support the laboring mom. And education before the procedure. If you take the time to let them know ahead of time, especially like maybe with a laparoscopic procedure where they have to inject air in there for the camera to see, a lot of times after those laparoscopic procedures, you're going to have some referred pain in your shoulder. That air just tends to travel up into your shoulder. If you let your patient know ahead of time, you may experience some shoulder discomfort after your procedure that's unrelated to what we've done. Knowing that ahead of time will ease that anxiety afterwards. So putting that education piece in there helps reduce that fear and anxiety, and then preventing the pain. Boy, staying on top of pain. This is something that I talk to my patients about a lot. Don't get behind the pain curve, is what I call it. So a lot of times patients will have, initially they may have scheduled medication, and they may also have some PRN, some on-demand medication. If they wait and they tell you, oh my gosh, my pain is now a 10, and then we give them pain medication. By the time that pain medication works, it may not bring it down enough until it's time for more pain medication. If they tell me their pain is maybe a 5, and we get on top of their pain before it's unmanageable, then we stay ahead of the curve and we can manage their pain a lot better. One of the better ways for the patient to manage their own pain is the patient-controlled analgesia, or the PCA. So the PCA is set to give a prescribed dose. So this is an order from the physician or the provider for the medicine to be given. There is sometimes a loading dose, and there is a prescribed dose for how much they get, and there's a prescription on how often they can get it. So the nurse will get this in the tube, hook it up to the pump, hook up the pump to the IV, and this is where you really have to educate your patient about what they need to do. It's not just as simple as pressing the button. Now that is all they have to do to get it, but every time they press the button, they don't get medicine. They're only going to get medicine if it's within the prescribed limits, but the machine is recording every time they push the button. So part of your documentation for that pain is asking them still, what is your pain level? And you'll look at the machine and it will tell you how many times did the patient demand medication. And it will also tell you how many times they got it. So by looking at how many times they demanded it and how many times they got it, may be able to tell you that you need to engage with the provider to say, their pain isn't well controlled. They're pushing the button every 30 seconds, but they're only getting medication maybe every 10 minutes or every 30 minutes, small doses. So, your experience with PCA is pretty much the same?
Yeah.
Yeah.
That you asking me?
Yes.
Yeah, right, so they, you're documenting how often that they're asking for it. You know, you have patients that are gonna push, you know, like crazy, and if that's a placebo effect for them, that's fine, but you still have to document how many times they push it, because the PCA will not overdose the patient, it is maxed out. But it still requires nursing assessment, because even if they're getting 1 milligram every 10 minutes, so 6 milligrams in the hour, that still might be too much for the patient. So you're still doing your appropriate nursing assessment, assessing their respiratory rate, their heart rate, and making sure that it's not having any ill effects on them as well. Did you have a question, Kate?
Yeah, can you use like the number of times like the PCA was used as like an evaluation of pain?
It is. So that's letting you know how much they've demanded. And so that's a good way for you to talk to the patient to say, I see you're pressing the button a lot. Are you having pain every time you're pressing the button? And, you know, check their mentation status. They may think that's the call bell. They may think that's the button that moves the bed. So that's where this patient education is important, is very important, that they understand. But that they are in control of their own pain medication. There have been so many patient satisfaction studies that have said that patients are much more satisfied when they are in control of their own pain medication administration, that they have used less pain medication when they're in control of their own. Like we were saying about earlier, why are patients not saying, hey, I need pain medications? This is one of those things, that they're in charge of it themselves. That they don't have to, quote unquote, bother the nurse, and that it's administered through the IV, so it's not a shot. So this is usually only for, you know, the very short term post-operatively. This is not usually something that's a long-term thing.
And also in the same respect, it's patients not pushing the button. Because I see you haven't pushed the button in the last hour, and you're feeling comfortable.
Mhm.
Maybe it's time that you can discontinue the PCA
Right.
as well.
Yes.
So you're not requiring as much anymore.
Right. And if you notice, but this was a question I think I saw in the previous lecture, was if you go in and you notice, boy, this person looks like they're in pain. I'm helping them up to the bedside and they look like they're in pain. And you say, I noticed that you haven't pressed your pain button. Here, let me press the pain button for you. Is that okay? Very good. So, this is something that they're supposed to do for themselves.
And family can't do it.
Right, and family can't do it either. So, kind of in Western medicine, we're going to say that there's a large emphasis on pharmacological interventions. But there are many non-pharmacological interventions that will help. Now, physical intervention, that physical movement, that can really help. So think about how we tell laboring mothers, get up, walk around, sit on the ball, bounce on the ball, or people that will bang your elbow, you know, when you've hit your elbow and you've hit your funny bone, how you kind of rub it. That's that physical intervention, that's kind of that gait control a little bit too, is modulating your pain that way. There's cutaneous stimulation, either the TENS, the transcutaneous, or the percutaneous. The transcutaneous, the TENS units, I'm a big believer in those. I have one at home myself, and I really like it. Massage, who doesn't love a good massage, right? And then the application of heat or cold. There is a really great intervention of using cold in orthopedics. It's a cryo cuff. Has anybody done an ACL or had a knee injury that's used a cryo cuff? Isn't it great? Mm-hmm. I mean, this is how you get wealthy in medicine, is to invent something so simple but so necessary, because those things run $500-700, and it's an igloo cooler hooked up with a hose to an ACE wrap, basically. But that's how much they cost. So that's what it
Did you
is.
see those in clinical this week?
You may, I don't know.
Yeah, I bet you saw them and you didn't even know what they were.
Yeah.
A little cooler at the bedside, you fill with ice and water, and it constantly circulates cold.
It's so wonderful.
Around the patient's knee.
You put a little igloo cooler, you have ice and water in it, and about every 20 minutes, because that's about all you really want to put ice therapy on somebody, is about 20 minutes. And the little hose, for gravity, you raise it up, the water runs into whatever joint you need it around, your shoulder or your knee, and then you just connect it. And that water, that cold water, is going to help shrink those tissues, decrease inflammation, and decrease that pain. So in most places, you do need an order for heat or cold therapy. The other two I have up here that are really good, acupressure and acupuncture. You do have to be licensed to do both of those things. Contralateral stimulation, that kind of goes along with the acupressure. If you're having pain on one side and you apply pain to the pressure to the other side, you can kind of, that gait control, interrupt that. And then immobilization and bracing, especially for some of those orthopedic injuries. As soon as you get that bone and joint back into the location that needs to be and stabilize it, that helps a lot with that pain. So the last step of the nursing process then is evaluation, and this lets you know if your plan was successful and if you need to change your plan. So on your MAR, it's going to ask you and require you mostly to document what was their pain level before you gave them the medication and what is your pain level after the medication. This is an important thing for you guys to know, and it's discussing your pain goals. So we talked about pain tolerance. What is that level and what can you endure? So when we were talking about that Mankowski scale, that kind of 0 to 10, that 4 to 7, it distracts me. I can take a low-level pain medication. These are the pain goals that you need to establish with your patient. What is the pain that you can tolerate, and what is your pain goal? Now, for someone who is a fresh post-op, it would probably be an unrealistic goal to say, my pain goal is 0. So make sure that you set a realistic goal with them and that that goal is attainable. But really find out from them. Some people, their pain tolerance, they could tolerate a 4 or a 5. Some people can only tolerate a 1 or a 2. It's going to be, again, that subjective and whatever the person says it is. So really listen to what the patient has to say about what their tolerance is, and what their goal is, and help you make your evaluation, make your plan so that you can reach those goals. So we need to check if their pain level has changed after your intervention, if the quality has changed. Has it changed from a sharp pain to a dull pain? Has it changed from an ache? How has the quality changed? And can the person return to their work or their usual activities? That's usually a great indicator if their pain is tolerable. Can I go back to work? So then these are some more of those non-pharmacological methods. Distraction, being active, watching TV, having their visitors in the room. The spiritual interventions, for those people that want to have their spiritual advisors come visit them, for patients that you feel comfortable praying with, that's always a wonderful option. Music and hypnosis and guided imagery, these are all things that we strive to have time for as nurses, and as you guys are in your first time with clinicals and you have that one-on-one time with patients, these are the times that you have to engage in more of that interactive time. It's sad to say that as you get further along in your career and you're more busy with patients that you don't have this time to spend with your patients, but I always try to find the humor in the situation, but then also keeping their room dark if they're a person that wants to be quiet and reflective when they're having pain, trying to be respectful of how they manage their pain, and offering them to be reflective about their pain, especially those that are having the chronic pain and the cancer pain. So pain control is that goal. Managing their pain at the lowest pharmacological level. So we have here this little step ladder where step 1 is trying to use the lowest level, a non-opioid, a non-steroidal, something aspirin, or just one of the non-pharmacological interventions that we talked about. If that doesn't do it, if the pain's persisting or increasing, then we have to step it up. This is where I was talking about staying ahead of that pain. If we don't stay on top of it, then we have to increase, have to add to it. We might have to add a weak opioid. And then if it's still not getting any better, we might have to go to something even stronger. But when that pain's controlled, that's what we're really after. Because all medications have that side effect. And what we talked about before, why patients don't request it, like Kate said, we're worried about dependency. So there's that physical dependency where they're not actually chemically addicted to it, but they just feel like they need to take the pain medication. They're afraid of having pain, so they take the medication. And that's psychological. But then we also talked about some of the risks of that in previous classes, where taking those opioids causes respiratory depression. And then there's also the issue of tolerance. After you take that medication for a long time, do you develop tolerance to it where the same level of medication isn't working for you anymore and you start to take more? So now we get to some questions. This is for you guys. So tell whether the following statement is true or false. The best judge of the existence and severity of a patient's pain is the provider or the nurse caring for the patient. I see a shaking head. That means
No.
no. False. Correct. Who's the best judge?
The person offering
The patient.
symptom.
Yes. Question 2. A female patient is being evaluated for a possible myocardial infarction and she complains of jaw pain. The nurse documents the patient's pain as what type of pain? Is it transient, superficial, phantom, or referred? Referred. Very good. Here we have Mr. Wright is recovering from abdominal surgery. When the nurse assists him to walk, she observes he grimaces, he's moving stiffly, and becomes pale. She is aware that he has consistently refused his pain medication. What would be a priority nursing diagnosis for this patient? Bless you. Bless you. Okay, impaired physical mobility related to surgical procedure.
C.
I'm thinking more along the lines of C.
But he didn't say that he's afraid. That's assuming that he's afraid of taking medications. He might be not taking them for some other type of reason that isn't fear.
I agree.
I loved
It
it.
doesn't say like what the P score was, it just says that he's like, he could have given I have a 10 out of 10, but
Right.
it's just, he's
Right.
refusing pain medication.
Exactly.
They can still have a 10 out of 10.
True. I love hearing you guys' rationale because I remember seeing these questions and feeling the same way about them too. But I want you to think about what lecture we're in. It's a pain lecture, a pain question. So he's having acute pain. He's demonstrating pain with the grimacing and the moving stiffly and becoming pale. Those are some of those nonverbal cues that he's exhibiting. So, but I can see where you can come up with that other one too. All right. Questions for me?
Is that your dog?
No, but my parents had a Westie. I just loved his little head tilt when you don't understand.
Any questions, guys? One thing I would like you to pay attention to is, when you're thinking about pain medication is important. We have to medicate for pain, especially post-op pain. It's the number one reason people seek care in the hospital. But, we also, and if patients are refusing their pain med, we also need to think about the healing process. What do we need them to do? We need them to walk and ambulate. We need them to cough and deep breathe, right? We need them to change position. So we need to allow them to be comfortable enough to do those things. So pain med, even when they refuse it, is important because we need to explain why it's important that they're going to be comfortable enough to heal.
Yes.
Right?
Yeah.
Because if they don't cough and deep breathe, they're gonna end up with pneumonia. If they don't get out of bed, they're gonna end up with a DVT, right? So we gotta make sure that we do get them comfortable enough to be able to do those things. Thank you very much.
Thank you.
So,
I'm gonna pass around the attendance. This first one is just for me with just your initials, and the second one is for Professor Hanford.
For me.